and there is data, but you know, it doesn't always agree. I've done my best to go through and talk to different clinicians at the Leprosy Hospital, at the Stenosis Institute, and multiple podiatrists throughout the U.S. And one that really helped me was Dr. Stephen Gaynor in Florida, who's a podiatrist, and then he's also a Pedorthist, so podiatrist and a Pedorthist, so he was great. They asked me at AAOP to put this slide in. The first time I was going through and kind of practicing, I actually read this really quickly. I have no financial hardships to disclose. I thought, well, that's not right, especially after coming from Canada and having a drink at the bar upstairs, but I actually do not have any financial relationships. So again, I'm a CPed in the US and Canada, a chiropractor, trained in the amputation prevention, and part of this diabetic foot stream committee, which, yes, we don't know why the word stream is in there, but we did create these guidelines in 2017 on preventing ulcers and amputations. And just being able to work up and down the kinetic chain gives me a good perspective, because we're seeing this advanced neuropathy and these deformities in the foot, not just with diabetes, but also with stenosis, which is the #1 degenerative condition, which also causes neuropathy from the top down. And it can also cause Charcot foot. And so it's really important, as we have an aging society, that we're able to recognize when we see advanced neuropathy problems from other issues. I just want to take a minute to recognize my instructor in Pedorthics. This is Bill Meanwell. He's no longer with us, but he was an amazing, inspiring instructor. He's the one that said, does anybody know him here? Yeah, that's great. He was a big contributor to these events. He was the one that first said to me, you know, we have more diabetic patients here in the US than you have all of population in Canada. And I thought, really? And then at that point, I didn't even know that diabetes even affected the feet. Like, we just didn't learn that. I'm sure I had Charcot patients come in and out. We just didn't really learn that at school. So he was the one that got me really interested in this path. So today, this is what we're going to talk about: the progression of neuropathy, the intrinsic minus foot, or the laterally column loaded, the collapsed mid-tarsal foot, or the medial loaded, and then we'll talk about the intrinsic minus foot from lumbar stenosis, because you all are going to see this, because as the population ages, and 70% of the over 70 have lumbar stenosis, you're going to see more and more of these patients walk into your office. And we've done research that a lot of times this diagnosis is missed, neuropathy, from the stenosis patient. So it's really, we're going to see how to pick that up today. Oh, and then we're going to talk about protecting the diabetic foot. I should actually say protecting the neuropathic foot, because it can come from multiple sources. So what is the intrinsic minus foot? So intrinsic, what's happening, it's an imbalance between the flexors on the top of the foot the extensors on the top of the foot, the flexors on the bottom, and it's an imbalance. This term was first coined in 1976. And what happens, we're losing the plantar muscles, they're denervating, because the process of neuropathy takes out the most distal nerves first. It denervates those small muscles on the bottom of the foot. The extensors then take over and deform the foot into what we see here. So we've got the equinus in the Achilles, we've got the extensors taking over and causing the hyperextension here, the flexion in the toes. We're getting the hollow foot morphology, where the intrinsic plantar muscles, the lumbricals and the interossi, are denervating. We're losing them, and we're getting this distortion of the foot, which leads to a foot that is weight bearing on the lateral side of the foot. So it's lateral column loaded. Now, what makes this confusing and not everybody agrees with is there is the intrinsic minus foot that looks like this non-weight bearing, and then when it's weight bearing, it becomes more pronated or medial column loaded. But we can't talk about everything, so we're going to take out this piece, that piece. We're going to talk about the lateral column loaded because we do see this in practice. And this is one we want to pick up because there's not a lot of shock absorption here, and these areas are the most common to ulcerate. But we can't talk about the intrinsic minus foot without talking about the medial column loaded foot. And in terms of weight bearing, there's more weight going through the medial part of the foot. So when we're dealing with the neuropathic foot, it's wherever the abnormal forces are, the pathological forces, whether it's lateral or medial, that's what's going to create a callus. That's what's going to create a wound. Wounds get infected, lead down that very deleterious pathway. So when we see this, we've got more of the convexity here in the medial column, and we've got the inversion of the talus here. This is also very pathological for the neuropathic foot. These are the IDF clinical practice guidelines. I encourage you all to Google the IDF website. These guidelines are fantastic. They're broken down into these multiple categories: neuropathy, arterial disease, ulcers, diabetic foot infection, and the Charcot neuroosteoarthropathy. So there's a lot of information in this. The whole focus of the guidelines is neuropathy, checking the patients with the 5.07 monofilament, which picks up 10 grams of pressure on the foot. So we can check 9 plantar, 1 dorsal. If they can't feel even one area, they're going to move forward in the risk categories. So this is a great chart that is on the website here. And you can print this off for in clinic. So it starts with risk category 0, then it goes 1, 2, 3. So risk category 0 is they have no neuropathy. They're in good shape. They just have to keep their A1Cs below 7 and get checked in a year's time. Risk category 1, which is moderate risk. They can't feel even even if they can't feel just one of the monofilament areas, then they're already elevated into risk category 1. And then they move up to risk category 2 if they have fungus, onychomycosis, if they have peripheral arterial disease, if they have a painful foot condition or a problem with range of motion. They get moved into risk category 2. And then 3, which I always tell my patients, we do not want to go anywhere near 3. That is an ulcer, amputation, or a Charcot foot, or a history of ulcer, amputation, or Charcot foot. So I always tell my patients, it's good to be a 0, right? That's where we want to see you. That's where we want to remain. And even if they're up at 1 and they're all worried, I say you can live very happily as a 1 and never progress up the categories as long as we're protecting you. And so online it also comes with this nice little pocket chart here. So this is the quick diabetic foot exam. This is all online as well. The goals of the guideline is early intervention. We want to work with these patients quickly and aggressively in risk category 1 and 2 to prevent them from getting to 3. And we call that the window of presentation. That's where they're presenting with neuropathy, but they haven't got to 3, so there's no ulcers, amputations, or ulcers or amputations or Charcot foot happening. And the second is the mobility. Keep these patients on the ground and walking so they can manage their blood sugars, so their blood sugars don't elevate above the A17 and they go down this deleterious pathway. So they have to be able to monitor or to walk to keep this the neuropathy from progressing. So what we're dealing with today is the pathological forces on the diabetic foot. that will destroy the diabetic foot. And then we want to find them, we want to identify where they are, and then we want to offload them. So in practice, we see patients really quickly. We don't have a lot of time to talk, and the patients often, it's the first time they're hearing all this. They don't even know what neuropathy is. I mean, they did a study of 23 patients that got an amputation, and 22 out of the 23 had no information on neuropathy. They didn't understand protecting the diabetic foot. Like they're not getting enough information. But in practice, I always think the quickest thing to explain to them once they know they have neuropathy is it needs to be offloaded. And that's kind of a coined term. What is offloading? I always say, take your finger and poke it. You can do it with me now. Poke it as hard as you can into your thigh, right? It hurts. Now take your hand and push it. You've increased the surface area. You can no longer hurt yourself. The patients get it immediately. They're like, oh, that's what we have to do. So it all starts with glucose. So diabetes is a disease of excess glucose. Glucose is a highly reactive compound. If it's in the bloodstream, it has to be metabolized. It will wreak havoc in the bloodstream. Normally normally glucose is insulin dependent. It needs insulin, the hormone, to uptake it, to bind to the receptor site in the cell, to turn the key, to unlock the door, to get the glucose out of the bloodstream, which we want, into the cell. Now, what happens in type 1 diabetes is there's not enough insulin because the insulin is produced in the beta islet cells of the pancreas. So there's not enough. It's not working, it's not getting enough insulin to get the glucose out of the bloodstream. In type 2 diabetes, it becomes insulin resistant. So they have some insulin, but it's weak because it's so impeded it's so desensitized because there's so much glucose in the bloodstream. And then also the fat of overweight people with the fat impedes the insulin, makes it weak and resistant. So now the insulin doesn't have the strength to turn the key to get the glucose out of the bloodstream. So the glucose wreaks havoc in the bloodstream. There's 3 tissues that are non-insulin dependent. That is the neuron cells, the kidney, and the retina. And that is where it wreaks havoc. So we're talking about glucose affecting the smallest neuron cells in the foot and the smallest blood vessels in the foot. What happens, as well as wreaking havoc with the neuron cells, the glucose crosses into the smallest blood vessels in the foot, damages the endothelial lining in these blood vessels, which then we don't have the blood vessels to nourish the nerves, and then we don't have the nerves to nourish the blood vessels, because there's an interplay between the two. If we don't have one, we're gonna lose the other as well. The neuropathy just means nerves dying. The nerves start to die. The patients are going to get numbing and tingling in the feet at rest, eventually become constant. They're going to get sharp shooting, lancinating pains down their legs, the sensation of bugs crawling. It can be painful or not painful. It's actually helpful if it's painful because then it gets them to come see us for protection, because otherwise they can just silently ignore it. So the glucose starts to kill off the nerves in the feet. How it does this, again, it works distal to proximal, and it takes out the large myelinated nerves first. That is the motor nerves. So that's going to affect the small muscles in the foot first. So that's going to be the plantar muscles. And then it starts working up. It starts with the intrinsic muscles of the foot, are the ones that are below the ankle. So those ones, that's why it's called the intrinsic minus. I should have actually explained that. It's called the intrinsic minus because it takes out those intrinsic muscles below the ankle first, because that's where it'll start, and then it'll work with the extrinsics above the ankle. So when we lose motor, the first one, we're also going to lose the muscle spindles and Golgi tendon organs, and all that information that is our proprioception and our position sense and our balance that is giving the afferent feedback to the central nervous system. So these patients literally don't know where they're placing their feet. And because they don't have the afferents, they're also losing the efferent from this central nervous system down to their feet about how to fire the muscles. So that's why they're so unstable. The next one to be lost is the small myelinated nerves, which is the sensory. So first light pressure and then deep pressure. And then the third one is pain and temperature. So that's why when the first two are lost, everything feels hot and cold to these patients. So why is the neuropathic foot different? Well, we've got the motor neuropathy. We're going to lose the balance or the proprioception position sense from the motor. We're going to lose the intrinsic muscularity here. Then we're also going to lose the autonomic neuropathy, which takes away the sweat and the oil glands, so the skin gets very taut and more available for ulceration. And then also the sensory neuropathy, which is the loss of feeling in the foot, and also it'll be the loss of the light and the deep pressure as it progresses. So to delve a little bit deeper into the intrinsic minus foot, the extensors are going to distort the foot from above the extrinsic muscles are going to distort the foot here. So we're going to get the hyperextension of the MTP joint. We've lost the lumbricals here, which are the major flexor here, and the extensor of the IP joint. So we're going to go into flexion here. We get the hollow foot morphology in the arch here. We're going to, as well as atrophy of the plantar muscles, we're also going to lose the fat pad on the heel and the fat pad under the metatarsal head, and it's also pulled distally, so it's further exposing these areas. Often also the Achilles, we get the Aquinas syndrome we talked about as, and we're going to get into that, as the Achilles glycosylate stiffens up, we're going to get the cross-linking of the collagen in the connective tissue. This whole foot becomes rigid, and now it can't do the two things it's supposed to do, which is adapt to terrain and absorb shock. So it puts these two areas at risk. All the weight bearing is on the medial calcaneal tubercles and the metatarsal heads. So when you have a round area on a flat surface, you're going to have a very high peak pressure area, and that's what we've got on the right here, the medial calcaneal and the metatarsal heads. Areas of peak pressure are going to, the body's going to try to protect this. So we create a callus, hard nodule of skin, because the body's trying to help protect us, because otherwise it would open up straight to an ulcer. So, but the problem is these calluses are just like taking a rock and taping it onto the bottom of the foot. So you can see right here, this is a rock, this is a callus. So there's no difference between the two. It's like taping the rock on, telling the patient go for a walk. So one, it will be painful, but they probably can't feel. And then the other one is it's going to actually end up ulcerating up. So that callus needs to come off immediately, because otherwise calluses will open up into wounds. And now we have an open portal of entry right here, which is going to allow in bacteria, fungus, and it can work synergistically in the bloodstream to create a very deep infection that can take this patient's foot. So when we're talking about limited joint mobility, again, the collagen and the glycosylation of the tissues is the collagen and connective tissue. It's going to be cross-linking. So it's going to stiffen up the Achilles tendon, which is going to bring the forefoot down to the ground. So there's going to be more pressure on those metatarsal heads. but it's also going to be affecting the plantar fascia that we talked about today. It also affects the capsules and ligaments. So the whole foot starts to stiffen up. Again, it has difficulty adapting to terrain. We're going to get these high peak plantar pressures. And then the repetitive stress of walking. When these patients are not neuropathic, the studies are showing the patients don't have to alter their stride. They can just keep walking on the heel, on the forefoot. They don't alter their stride because they don't need to. There's no feedback to the brain saying that they are damaging the tissues. So we're going to get ulceration in these neuropathic individuals. When these happen, these are not just little red markers. These wounds are a big red flag that these patients have a very limited mortality. The studies show that it's 55% will not be around in 5 years once we have these diabetic ulcers. So these need to be aggressively treated once they're open, but even better is to prevent them. The big thing this is worse. So it's not just the ulcers, it's actually the Charcot foot is the worst. So with this, the patient is neuropathic and they're traumatizing the foot. They don't have to alter their stride. So they're going to walk, and cause uncontrolled inflammation in this foot. That causes hypervascularity. So now we've got increased blood flow and chemical mediators going to the damaged areas in the foot. And the foot, we lose the mineralization in the bones. The bones become a loose bag of bones, but the patient's still walking on it because they can't feel anything. But the Achilles is strong, the extensors are strong, and the proneus is strong. And as they're walking on it, it's going to collapse the foot into what we see right here, the rocker bottom foot. So what we really want to do is catch these patients earlier in stage 0, which is the prodromal stage, which is when they're presenting into the clinic with a red hot swollen foot and a temperature elevation. So temperature is our best remaining index that the tissues are starting to break down. If we see 2 degrees elevated Celsius or 4 degrees elevated Fahrenheit in these patients with our temperature gauge on the dorsal of the foot, on the dorsal forefoot, the plantar forefoot, and the plantar arch and the plantar heel, we're looking at all 4 areas, then we know that there's a process going on. Either it's an infection, but if there's no portal of entry, it's going to be the beginning of a Charcot stage foot. That is a great place to find them in stage 0 because we can lock them up in a cast, in a walker, whatever we need to do, even a wheelchair, and then they will never progress to the next stage, which is the acute stage. This is where there's the bony dissolution and the bone is starting to remodel. So when we're in that stage, the acute stage, this is where we can x-ray them. We can't x-ray them in the prodromal stage, nothing's going to show up. That's the best place to catch them and protect them, but we're not going to, if we're not sure, we don't see them in time, the next best time is the acute stage. This is why I put this on, but I didn't realize it was going to be so small. When we x-ray them, we're looking at the second cuneiform to the second base of the metatarsal. So this should be perfectly contiguous. If there is even a 1 millimeter slipping here, that means they're most likely in this Charcot foot process. So again, you want to lock them up until the bone has a chance to remineralize and harden up, and then the patients can come out of their protective device into diabetic orthotics or diabetic shoes, and well, actually both. This isn't well understood, and just to give you an idea how non-understood this is, I had a patient that had Charcot, well, I have so many patients that have Charcot foot, but one specific that we caught, we protected, we put him in an air cast, and then we put him in diabetic shoes and diabetic orthotics, and then with his diabetes, he had to go to the hospital for other reasons. But while he was at the hospital, somebody stole his shoes and his orthotics. And then the hospital personnel said, "You're diabetic, you have to get up and walk." He's like, "But I don't have my shoes." And they said, "Okay, well, here's these plastics, these paper slippers they give you, right?" He's like, "Oh, no, Dr. Langton wouldn't like that. I'm not allowed to do one step without this." And they said, "No, you got to get out of bed and walk." So he had to go every day for like 2 weeks. He had to get out of bed and walk. And they just made him. And so at the end of that, he came to see me in 2 weeks later. And oh my God, he was going, it was all reactivated. He was now back in stage 0 of the Charcot foot, and we were starting again. It was actually a very sad story because we ordered him new shoes and rocker bottoms and new orthotics, and now the hospital had to pay for it. But he actually died before he could pick them up. So it was a very sad story. But we want to see these patients earlier. So now we're going to talk about the pathological forces that are causing these ulcers and this Charcot foot. So the intrinsic minus foot, or the laterally loaded, or the medially loaded. So let's talk about the lateral loaded foot. So again, that foot is bearing a lot of weight on the outside of the foot, whereas the medial foot, the medial foot is bearing weight on the inside of the foot. Okay, so this is the pronated foot, the other one is the supinated foot. And I know Seamus already touched on this, that was very helpful. So let's talk about the subtalar joint. So the subtalar joint, the talus here, the calcaneus, the talus is wedged in between the talocrural junction, right in here, the calcaneus, and the mid-tarsals here. It has no direct muscular attachment, so it cannot move on its own, must move with these joints. So the subtalar joint is called the body's steering wheel because it moves in rotation. It moves in these triplanar movements. So as the foot goes into pronation, we're going to, the heel is going to go in one direction, and then the talus goes in the opposite direction. Then when we move into supination, same thing. So we're actually, when we're looking at the balance of the pronation and the supination, we're looking at the forces being equal and opposite in direction. That's what we want to see. So when we go into pronation and supination, we want to have everything balanced. So let's look at the axis and let's take a look at that. So an axis is just a straight line through which an object can rotate. And Seamus already touched on this. The subtalar joint axis is 23 degrees medial to the transverse plane and 42 degrees superior to the sagittal plane. The axis passes right like this, okay? As the body moves through the pronation and supination, the center of pressure, the average body weight coming down, is going to determine the direction of rotation into supination and pronation. Then we're going to see how the forces are balanced. So think of a teeter-totter. This is the best example. The forces in pronation and supination must be equally balanced and counterbalanced. Otherwise, the body will take the foot into a new subtalar joint area, into a new equilibrium. And that's where we're going, the pathological forces are going to cause problems. So let's talk about the moment. So the moment is the rotational force. Moment equals force times distance. So in order to have this balance, here's the fulcrum. Okay, we have this big kid that's 1,000 newtons. So this is the force. So force equals weight times gravity. 1,000 newtons here with a 1 meter Newton arm. So that's 1,000 Newton meters is the moment. And then we look at this little kid here. He's 500 newtons, but he's 2 millimeters here. Okay. So now these are in equal and opposite. This is in balance here. the force is dependent on the subtalar joint. Okay, so we're looking at the subtalar joint is dependent on the muscular, so with the intrinsic generated contraction of the posterior tibial muscle and the peroneal muscles. So the posterior tib moves us into supination, and the peroneals move us into pronation here. So there always has to be a balance between these two. The other thing we're going to look at is the ground reaction force. So the ground reaction force is the foot coming down on the ground and then the ground pushing back up, stopping the effects of gravity on the body. So it's Newton's third law. Every action has an equal and opposite reaction. If all of these aren't in balance, we're going to get pathological forces on the diabetic foot. So here's the fun part. So here's the normal subtalar joint access right through here. And this is the posterior tibial muscle. This is the major supinator in the body. Okay, and we're looking at the moment arm between the subtalar joint axis and the posterior tib. Okay, and that's nice and neutral. Now we're looking at, this is the peroneus brevis. That does 63% of the pronation moment. It gets some help from the rest of the peroneals, but let's focus on that one here. And so that's how long this moment arm is. So this foot is in balance here. What happens, what we're learning is these patients are that are medially deviated, so collapsed in the midfoot, or laterally deviated, the intrinsic minus foot, once they get diabetic, are already predisposed to this. So they are already a cavus type foot moving into an intrinsic minus foot, or they were already a pronator, and then moving into more medial column loaded. Because you have to take what you're given, and then diabetes will exacerbate and cause the ravages. You're not going to take a foot that's a cavus foot and or you're not going to take a pronated foot and just with the denervation and the neuropathy move into an intrinsic minus foot. That's what we're finding with the research. So now let's look at these patients, and we know that 67% of the patients are already pronators. Now we can see what happens is that as the subtalar joint axis starts to move medially, it's getting closer to the posterior tib. Okay, so the moment arm is decreasing. So now it doesn't have as much of strength to supinate the foot. And now you can see the peroneus brevis muscle, that moment arm is increasing. So we're getting an increase in distance that's pronating this foot. And then it starts to get worse with the effects of diabetes. And then we can look at the laterally deviated foot, and we can see that the peroneus distance to pronate the foot is decreased, and the supinating arm from the posterior tib is increased. So these patients are being pushed more into supination, which is what we see with these intrinsic minus foot that are walking on the outside that are, they're just about to topple over. They're very laterally deviated. Now we take the effects of diabetes and it exacerbates what they are naturally given. So again, we talked about the motor neuropathy, the autonomic neuropathy, and the sensory neuropathy affecting the foot type and also distorting the foot into what we see, the intrinsic minus foot in one sense, and the other is the collapsed medially loaded foot. The second thing we're going to talk about is the Achilles glycosylation causing equinus syndrome. Now I say here exacerbating because a lot of these patients before diabetes, they were already had equinus. They didn't exercise, they didn't stretch, they were overweight. They probably already had some equinus, and then it's exacerbated by the cross-linking of the collagen and connective tissue. And that is what's happening with the equinus, is that is lowering the forefoot to the ground. It's putting more pressure on the metatarsal heads, which is the most common area to ulcerate, and it's also putting a pronatory force onto the foot. So that affects the diabetic foot as well. Now we have to look at the third thing, and I mean there's lots of things, I'm just thinking about the top three that we see in clinic. So now we see we got a double whammy here, because these patients are gaining weight, and a lot of times we see the failure of the posterior tib. So right here, the posterior tibial muscle comes down here behind the medial malleolus, takes a right turn here. Already the blood flow is compromised behind the medial malleolus with everybody. In patients that have had a trauma, weight gain, or diabetes, it further compromises that blood flow that's already impeded. And then the tendon starts to fail. And as the tendon starts to fail, the foot elongates. We see the out-toeing here. We see the abduction of the forefoot. And they start to bear more weight on the inside here. Okay, so these are the medial column-loaded patients. As the tendon loses strength here, because they become more medially deviated, also they're gaining weight. So now you need more of a moment arm, more strength to actually supinate this foot, and they're gaining more weight and they have less strength. So we see this medial column deviated foot in a lot of these diabetic patients. So we can see here again that as the column becomes medially deviated, the posterior tib here does not have enough of a distance to supinate this foot. And so really this, if you think about it, this simulates the patients we see. 3% before diabetes or cavus. Now we're seeing about 10 to 15% go to this intrinsic minus foot after diabetes. 67% of the patients are pronators, and then we see that higher percentage in these patients as the medially column deviated patients after the effects of diabetes. And again, we can see this laterally deviated, the peroneus brevis tendon distance is decreasing, and we lose that pronation force, and these patients are they feel like they're going to get a calcaneal inversion sprain because they're very unstable. You can see them walking, and they're just neuropathic, and there's no shock absorption. All the weight's going through the fifth ray, the fifth metatarsal head, and they just have such an apropulsive gait. And with what you were talking about with the windlass, a lot of times in these patients, the windlass mechanism is completely inoperable. So some of these patients, they're just kind of picking up their feet and putting it down. There's no rolling through the gait cycle, so there's no shock absorption there at all. So the second thing we need to look at is the ground reaction force. Again, the foot's hitting the ground is pushing back up and stopping the effects of gravity on the body. And this is another big thing that we need to look at. So here's the subtalar joint axis right down here. This is the medial side. So with the medially deviated patient, there's more weight bearing here. Anything that pushes on the medial side of the foot for the ground reaction force, it causes a supination moment, okay? If it pushes on the outside of the foot, and we usually use the lateral forefoot as the marker here, and the medial calcaneal as the marker here, this is going to push into pronation. If we pushed right down here, this is where we know where it is the foot doesn't move either way. Okay, so what we're going to see is that as the patient becomes medially deviated, the distance, so if this was the line, the distance from the medial calcaneal to that medially deviated subtalar joint axis decreases. So we have less of a supination moment. And as it moves laterally, the distance arm between the metatarsal heads laterally and the subtalar joint axis is decreasing as well. So we have less of a pronation arm. And so do you remember that seesaw? These are going to be out of equilibrium and now causing pathological forces on either the medial or the lateral side of the foot. So again, the lateral column loaded foot is going, all the weight is on the outside, and there's when it's on the outside, there's a net supination movement from both the ground reaction force and the posterior tib pushing to the outside. And when we see the medial column loaded, we are going to have a net pronation movement from the peroneal muscles and the ground reaction force here. Okay, so now, wasn't that fun? Now we get to talk about stenosis. So stenosis is in 70% of the over 70. It's the most undiagnosed condition. We actually did research on patients that presented to a diabetic foot clinic with neuropathy, were sent in by the physicians, and it was actually stenosis. So you're all going to see this in your practice because they're going to come in because they're probably misdiagnosed and they really don't know what they have. Or their doctor sent them in with neuropathy and it could be something else. So what happens is, as the patients get older, this is the front of the spinal cord, this is the back, something is pushing into the front of the spinal cord and or the nerve that comes out of this foramen or hole. And remember, this same nerve then courses all the way down the leg. So what we see with degeneration is either the bony protuberance is pushing into the nerve here, or the disc is bulging, or the ligaments. Something's pushing into the spinal cord, one of those three, and or the foramen of the nerve going down the leg. And what that does is it causes an engorgement of the veins. Then the veins disrupts the cerebrospinal fluid. Then that causes a disruption of the spinal arterial nerves. So this nerve loses its blood flow. It loses its oxygenated arterial flow. And so it's getting crushed. And then it has to course all the way down the foot, and then with no nutrients. So these patients will get the same symptoms of neuropathy, numbing and tingling in the feet, at night and rest, or sorry, not at night and rest, but they will get numbing and tingling in the feet. They will lose full sensation in their feet, but they present differently because diabetes is bilateral and it's usually at night and rest, and then it works distally upward. This one works from proximal downward. So these patients are going to be complaining of symptoms when they're upright and walking because it's squeezing the blood flow. They're going to get numbing and tingling in the feet and or hip pain, leg pain, thigh pain, and or they're going to lose bowel and bladder function. But as soon as they sit down, because usually it's measured in time, somewhere from half an hour decreasing to 5 minutes, the symptoms all go away magically, right? So if they're getting hip pain just doesn't go away if you sit down, but it does if you release the tourniquet and increase the blood flow.
So are you saying that the difference in the lumbar spinal stenosis, when does the symptoms relieve? When they're sitting?
Yeah, because it's when you're upright and walking, it's squeezing the canal. And when you sit down, or it's dubbed shopping cart syndrome, you bend forward, it opens up the canal. So now these patients can, with a shopping cart, walk 3 times the distance. So, or if they sit down immediately when it gets to like a 10 out of 10 pain, it'll all go away. Whereas normal back pain, hip pain doesn't. So we know it's stenosis, and it relieves the symptoms, and then you can get up and walk. So what this does is this is killing off the nerves as well, and we're going to get the same problems that we do with diabetes. We're going to see the Charcot foot, we're going to see the ulcers, we're going to see and it's going to lead down the same pathway to amputations. And just to give you an idea, a patient came to my office, and she had so much foot pain. She's like, I've been to the hospital and to my doctor twice. I was diagnosed with gout and then an infection, then gout, and nothing's working. And then I could see her foot, so it was kind of a clue. It looked red, hot, and swollen, and I said, "You're not diabetic." She said, "No." I go, "How's your back?" She said, "Oh, I've had degeneration in my back for years. It's really bad." I'm like, "Okay, I think you have a Charcot foot. Let's check the temperature." "Okay, you do have a Charcot foot. So let's lock you up, into the," we actually put her in a cast, but then we had to take her out because she didn't have the balance and she had to actually go into a wheelchair. But then the foot solidified. We protected that Charcot foot in stage 0, and she never progressed down the lines. So this patient didn't even have diabetes. So that's what I'm saying. You can see these neuropathic patients, and they're from other reasons, but we still have to protect them the same. And actually, she came in with she was like a cavus foot, so she would have gone down that path because she already had she was starting to go down that path. But we protected her, and then we put her in the proper orthotic to decrease the forces on the lateral side of the foot.
So you're saying that if we actually have somebody that comes in with like a Charcot foot, but they're not diabetic, and they go, look for the back.
It could be.
Okay, so
Yeah.
that's a default. So if something comes in, it doesn't make sense. And,
Well,
and we
because-
can actually say,
but no,
have
yeah.
somebody check the back and see if anything's going on. Because it could be spinal stenosis.
Yes,
Okay, got it.
absolutely. I mean,
So that fits into the decision tree.
yes, because stenosis is not, we don't diagnose stenosis from an exam. So you don't have to be a chiropractor, because your job when they come in is differentiate them to stenosis causing neuropathy, diabetes causing neuropathy, or a painful foot condition. So it's actually just asking them, well, how long can you walk? Okay, 15 minutes. Okay, and then what happens after that? Well, I got a lot of pain in my legs and my feet, my hip, and okay, so then what happens when you go to the store and push the shopping cart? Oh, I can walk for 45 minutes then. Oh, okay. And then what happens when you're walking and after 15 minutes it's so painful? Then what happens if you sit down on a bench? Oh, it all goes away. Okay, so we think you have stenosis, especially if they don't have diabetes. We're going to send you for an x-ray and then an MRI to have it queried for stenosis. And then there's all these other things you can do, right? Because you can treat stenosis. There's a stenosis institute and there's exercises. So we really want to be able to pick that out and protect these patients as well.
So do you refer them to orthopedics or neurology?
Well, I don't, because
You don't,
only
but-
25% of the patients will get a surgery, and the effects of the surgery only last 2 years, because the degenerative process that caused the stenosis hasn't been changed.
Right.
So what I do is in Mount Sinai Hospital in Toronto is Dr. Carlos Amendolia at the Stenosis Institute, and he teaches a course. And so I took the course, and then also I got the books, right? Because you can all order these nice books for $20. You can just give them to your patients. Say, do these exercises, right? Because there's all these core stability exercises to open up the spinal cord to decrease the narrowing. Or you could find a practitioner to work hand in hand to refer back and forth.
What practitioner? What?
Well, so it's either in Canada, it's going to be a physiotherapist,
Okay.
or a chiropractor that's trained at this Stenosis Institute in Toronto. And you can, I'll give you my email, you can shoot me an email and I'll give you the link and everything.
Thank you.
But yeah, I mean, I don't know down here, but I would assume that these patients, well, Dr. Carlos travels all over the world training people, so I'm sure there's people down here trained. Okay, so this is the Leprosy Institute in Louisiana. When we're dealing with the wounds, we are dealing, what time is it? Oh yeah, you took some of my time.
You brute.
Okay, so this is the leprosy hospital. So we know with dealing with patients with ulcers that it's not what we put on them, dressings and medications, it's offloading, right? We talked about offloading. And so what we're going to do is identify pathological forces, decrease the stresses on the tissues, and we're going to use orthotics for that. So when we look at this stress strain graph here, we can see that this is where the stress is being loaded onto the tissues. This is the normal physiological response to tissues when there's stress placed on it. And what happens when it gets to this proportional limit, it's starting to deform here. And when it gets to the elastic limit, that is the point of no return that these tissues will fail. And then they actually fail up here past the yield point to the rupture point. So the goal is to increase the yield point by our treatment so these tissues can take on more stress and not fail. So we're going to do that using, we're going to talk about orthotics, but you can also use diabetic shoes. But whatever it takes, so we'll talk about orthotics, we're going to increase the surface area. So pressure equals force over area. Force is the body weight, that's the constant. We're going to increase the surface area. That'll decrease the pressure coming down. So it takes the foot from just a few areas touching, that there's too much peak pressure, and then the whole area is going to be a weight-bearing surface here. What to prescribe? So the orthotic is going to serve two effects. So one, when we use the orthotic, it's to balance the forces and the magnitude, and so that there's an E, and it's to engage the posterior tibial and the peroneals equally to manage the supination, the pronation moments. So that's one thing. And then the second thing, because it's cast to the foot, it's going to increase the neuromotor feedback to the brain about where you're placing the foot. So it's going to increase the proprioception position sense. And that's always helpful with these patients that have these issues in balance. So when we're talking about the laterally loaded column here, lateral column loaded, we have to do a number of things here. So first of all, this foot has no shock absorption. So we need to use the nice cushioning materials, the Diabetic Trilam, the Plastizote, the Poron, the EVA foam, if we have enough room in the shoe. Sometimes we have to make a hybrid with 2 millimeters of polypro and then put all the cushioning on top. But we need lots of cushioning here. We need to push these patients back into pronation. We can use I'm sure you're going to talk about it later, but we're going to be using the valgus wedges to push these patients back into pronation to decrease the stresses on the fifth ray and fifth met head. We usually need extra cushioning under the fifth met head. That's an area that ulcerates commonly. We need to have very high arch to fill this in. We need extra heel cushioning under the heel here. We need extra cushioning under the metatarsal heads here. We usually use a toe crest sulcus pad to decrease the clawing in the toes here. And the other thing is we need to address the equinus here. So often we miss the equinus. If the patient's complaining that the arch is too high, it's because we miss the equinus. If this isn't moving, the mid-tarsal complex has to move more. So we want to address the equinus with the heel lift, 2-3 millimeters. And then that is how we can decrease the stresses on this foot. And then put it in a shoe with a little bit of a rocker to give some more shock absorption here. And then the medial column loaded foot, again, now we got to push them into supination here. We're going to use the varus forefoot and rear foot posts. We're going to use the aggressive arch. We're going to use the deep heel control to engage the posterior tib. We could use the medial skive to engage the posterior tib. Again, the materials are going to depend what we have availability in the shoe, and usually we're going to have Plastizote and Poron here.
Excuse me, I had a conversation with Johnson & Johnson once, and with the media loaded, and I hit it up, and they said you need to, they're engineers, not clinicians, but the engineers that make hip implants. But Tom, you need to figure out free body diagrams. Oh, thank you, but I actually did, and what I found that we've never been told that actually creates liability for them, whatever that's in the story. But one of the assumptions when you talk about your medial column If you look at the assumption in the kinesiology textbook, it says if we have something with multiple segments, it is assumed to be a single rigid segment. So I'm saying that the assumption that's used in the textbook in this third edition, and in Newman's kinesiology goes, oh, I'm going to change that for fourth edition. I'm like, thank you, because a free body diagram needs to be expressed also as a fatigue body diagram where you're going to get collapse of the midfoot. They don't recognize that we have midfoot pressures because they were taught to us on the biomechanical level where we were on. I mean, I was looking at the textbook, I'm like, so I took his words to heart. So when you're talking about this, the reason is that the models that they gave us don't believe that there can be a midfoot breakdown. In the biomechanics world, we live it, but that's where the flaw is that it's a utopian model that you'll never have a breakdown at the midfoot. And I did not know that until just recently. Does that make sense?
Yeah, but I'm talking specifically in the neuropathic feet. So these are physiologically dysregulated individuals, and nothing is the same, right?
But when we're trying to do it by the book, I was saying that the book itself is actually wrong. So their assumption, like Bruce Willis is dead in The Sixth Sense, and you think he's alive. But what I'm saying is that we all think that we were given a model that says it can never fall apart. So their advice to us is that.
So the presented model of the foot is that it's like a prosthetic, meaning there's no joints within the foot. And you were talking about the subtalar joint and the tarsal joint. That's the reality.
There's a person in the room that is telling us, oh, it's all fine, and they're the ones giving us your external fixators. So they designed external fixators that you can yank on the distal on the metatarsal, and it's going to correct your Achilles. So they're going to rupture the midfoot before they're ever going to get plastic deformation on the back. I'm just telling you that there was somebody in the room, and I didn't know who was in the room, so I was constantly started questioning the biomechanical aspects of it. I'm just telling you when you're looking at. I'm sorry.
That's yeah. Let Dr. Langton continue.
Yeah, but thank you for that.
Yeah.
Sorry.
Okay, so the other thing is these patients are also going to get plantar plate tears, and that's the most important thing, and we see this a lot, is the plantar plate is the fibrocartilaginous ligament that attaches the metatarsal head to the proximal phalange. And what happens is when there is so much downward pressure on these metatarsal heads, the plate starts to tear and the plate starts to rupture. And then the flexors on the bottom of the foot can't hold the foot in the supported position because it requires an intact plantar plate. So what we want to do in these patients that are medial or lateral column loaded is we want to offload the pressure on the plantar plate. And that is going to be by using the metatarsal pad to offload the metatarsal heads. That'll decrease the stress on the plantar plates so that they don't rupture and tear. And we know when they've ruptured and torn because we're going to get an elevation of the digits and also a separation. And they're very hard to treat once we have a plantar plate tear. Sometimes it's misdiagnosed, it's often missed, and it's really important with these neuropathic, dysregulated individuals that we protect these from plantar plate tears as well. And I'm just going to, in the last few minutes, sum up here. So it is the orthotics, but also it's going to be Footcare nursing. Real quick, you can't just treat these neuropathic patients without looking at Footcare nursing, preventing little problems from becoming big problems, dealing with the fungus when we see it in this early level here, when there's just a small infection of fungus, and we know this onychomycosis is virulent enough to push the patient from risk category 1 to 2. So we want to deal with it when it's early so that we don't see it at this level. This is very difficult to treat because you either have to treat these patients with topicals or oral antifungal medications. The liver testing for the for the oral medication is very toxic, and a lot of the patients will not be able to go on the orals anyways. The topicals are very expensive, so what do? So you are really need to see this earlier on and make sure that you address the fungus so it doesn't get to this level. Because otherwise these thickened toenails, because the fungus is feasting on the keratin in the nail. It has an affinity, and then the nail is over responding by laying down more more keratin here. The thickened nail will ulcerate the neighboring digits.
I know you're on a time crunch.
Want to go back
to that? Yeah.
Okay.
What if you see that on someone who's not diabetic?
Yeah. So the thing is with fungus, it is, the doctors always say, oh, well, it's just cosmetic, we can treat it or not.
Right.
So if they're not neuropathic, then they can keep their fungus if they really want. I mean, the problem is it's going to cross-infect into the skin, right? And it's going to attack the epidermis, and then it's going to cross-infect into the fingers, and then it's going to cross-infect to whoever they share the shower with. But it's probably not going to kill them, but, right, their spouse might, but the real risk is when they're neuropathic and they're going to get a wound, because once there's an open portal of entry, the fungus and the bacteria get into bloodstream together, and then it works synergistically to create a very deep-seated infection that can overwhelm the host's ability to fight the infection. So yes, we see them more likely in diabetic patients because the fungus just loves the sugar. I mean, it puts out the welcoming mat, right? So it's really, you can treat it or not if they're not neuropathic. When I see them in my office and they're not diabetic, I'm like, okay, well, you can see my Footcare nurse if you want to treat. It's really up to them.
Right.
But if they're neuropathic, I'm like, hey, you have to see my Footcare nurse. You have to get this treated. This is pushing you from 1 to 2. Look, you're closer to risk category 3. You want to be here? No? Okay, well, we can probably bump you down if we get rid of the fungus. And then it's very motivating, right?
Yes.
Okay, so the gaps in treating diabetic foot disease we're closing up. Window of presentation we talked to. We want to treat aggressively in risk category 1, 2 before they get to 3. We want to treat them and escalate and refer appropriately. There is so many other reasons here why that are gaps that are leading us down this deleterious pathway here. There's so many reasons. But if we miss these, we're going to see ulcers. And ulcers, again, 55% of those will be dead within 5 years. And 1 in 5 will lead to a lower extremity amputation. 50% of those will be dead within 5 years, or 3 years for an amputation, and then 80% within 5 years. And now the big thing here is diabetes-related amputations are only second to lung cancer in its mortality rate. So it's above colon, breast, and prostate cancer. Now everybody knows that lung cancer is going to get you, but they don't actually realize that diabetic amputations are just sandwiched under lung cancer. So that's a big thing. So by the time we get to here, this is a really big problem because this patient, there's been so much time that has passed to either get to here. A lot of checks and balances were lost along the way. So treating the pathological forces of the medial and lateral loaded columns, where we could have balanced the forces, treating foot care nursing, treating with education, treating the fungus. So they've gone down this pathway that, you know, a lot of times it's 85% preventable. And now the last thing we have to remember is that preventing diabetic foot amputations and helping keep the patient's foot attached to their body is, the research shows that it's location-based care. And what that means is you would think that it's the care the patient's going to get is going to be based on socioeconomic status or finances or education. You would think that that would affect the patient's care. But what they find is that it actually is the location that the patient lives and the knowledge and interest that the healthcare practitioner in understanding this has, and that affects the outcomes with these patients, how successful they do. So that is like, it behooves us all to do our best when we understand that it really is location-based care. So in this presentation, I just want to point out that the death rate from diabetes and its complications used to be 1 every 7 seconds. And now, in the last few years, despite advances, technology, more patients, people practicing and understanding this, and more medications, the death rate has actually increased to 1 every 6 seconds. Okay? So this is not good. We're going in the wrong direction here. And that is the end. Thank you very much.
Thank you so much. That was a great amount of information on many aspects of the diabetic foot and treating the neuropathic foot. If there are maybe quick questions, we can take 1 or 2. I would like to have a short break before we have Dr. Kogler on at 11 o'clock. Any questions for Dr. Langton? No, unfortunately you're leaving. It'd be great if you could hang around, but you got to go.
Yeah.
But I thank you so much for coming all the way from Canada and for sharing your expertise and for the work you do with the IDF. So thank you once again. Okay?
Thank you.
So Dr. Kogler is getting set up.